GI is an area that is really changing rapidly. There are a lot of innovations occurring that are obvious and being introduced into clinical practice. There are a lot of concepts and ideas that are right now going through FDA approval processes and in various stages of different clinical trials. I think the next 5 years we're going to really see a huge swing towards minimally invasive therapies, improved diagnostics, and even some additional therapeutics and disease management strategies that will be things that we can apply on an ambulatory basis and potentially even in the office. Well, what is upcoming in endoscopy are a number of things. We're going to be seeing a fair amount of innovation and then clinical application of new technologies to really enable endoscopic submucosal dissection, ESD, full thickness resections, and technologies to really bring endoscopic mucosal resection to a wider variety of physician practices. These will make it easier, quicker, and hopefully also safer for all. The role of personalized medicine GI is going to expand. It really has been an area that has been really bereft of applications. What we will start to see, and we are starting to see already, for example, in hepatology, is the ability to select the correct medication for the correct patient. I think we're going to start to see that more and more in IBD, and analogously, we'll start to see the selection of patients for endoscopic and tissue resective therapies based upon the likelihood of progression of the disease and cure of the disease by endoscopic minimally invasive modalities. The evaluation of patient risk is really a great area for expansion in GI. It's something that can be done potentially just in the office, something done as an outpatient, and depending upon whether or not one's going to use either stool sample, blood sample, saliva sample, a cheek swab to look at these different markers, it's something that really will be widely applicable and hopefully readily accepted by patients as a way to stratify their need for additional tests. If we can find patients who are at low risk and don't need any interventional or invasive testing, that's fabulous. And if we can get there and tell someone and give them reassurance, we've all won. I think we're going to see some very interesting technologies over the next few years that will help improve overall patient safety. Not just in terms of infection, but also in terms of early detection for failures of therapy and for potential complications of therapy. As big data really becomes more and more accessible and is less of a theory, but more applications are seen in GI, I think we'll be able to have early warning signals of infections, such as those that were transmitted by the duodenoscopes. And we'll also be able to look at data to help us potentially predict recurrences of diseases or disease markers as we progress. So I think the areas of minimally invasive surgery and trans-orifice surgery are really ripe. There's no question that POEM, the ability to really treat achalasia now without surgical incisions, is the prime example of the move in this area. I think we really need to look more and more towards what I think we'll end up calling organ-preserving surgeries, where we're able to treat just the area of the pathology, whether we treat it with resective technologies, ablative technologies, chemotherapy, or radiation is not clear to me, but we will be moving toward really leaving the patient without lasting scars and remembrances of having to have an organ removed. The AGA Center for GI Innovation Technology really is the home for bringing together gastroenterologists, innovators, payers, and the FDA in order to really try and bring some of these exciting upcoming technologies into the patient arena. the next few years will be great, and it's really been fabulous working with the center, and I hope to see the center continue to flourish over the next few years.